Good morning, everyone. I'm Chen Yao from the First Affiliated Hospital of Sun Yat-sen University. Thank you so much for inviting me to attend this fantastic meeting. It's my great honor to be here. Today, I'm going to talk about how to optimize infrarenal AAA sealing with angulated necks by using a new conformable AAA EndoGraft. As endovascular specialists, we frequently encounter hostile neck anatomies in AAA cases, which include short necks, conical shapes, severe angulation, and so on. These anatomies are often unsuitable for standard EVA. They may require adjunctive procedures and are known to carry higher perioperative risk and lower long-term survival rates. When we treat patients outside the instruments for use, we expose them to an increased risk of stent graft complications, such as endoleak, migration, occlusion, and kicking. Studies show up to 58% of AAA are treated outside EndoGraft the instructions for use, which is a significant concern in our daily practice. So what are the specific risks of treating angulating necks? There is increased risk of type 1 endoleak. High neck angles critically affect graft fixation because extreme curvature reduces the effective sealing zone. Complete wall opposition is often unattainable, leading to a higher risk of sac expansion, increased need for secondary reintervention, and even proximal device migration. It's very important to remember that not all EVA devices are the same. Early generation EVA devices were designed for standard EVAs, AAAs. As a result, patients with complex anatomy often require additional techniques to fully exclude the aneurysm, such as aortic extender, chimney techniques, and endo-anchors, which Dr. Huang just talked about. These techniques result in more components per case and additional costs. Furthermore, every aorta we treat is unique. They come in different lengths, angles, and with various abnormalities that create unique challenges in treating each patient. So we need a graft with the conformability to maximize the seal in each patient's unique aortic neck. This brings us to the next generation solution. So now we have gore extender conformable AAA endo prosthesis with active control system, which called EXCC system. This device was designed specifically to address the limitation we just talked about. It can maximize the seal zone through optional angulation control, enhanced device positioning, and conformable stent graft. This combination gives us an opportunity to achieve optimal seal, even in very difficult necks. So EXCC system not only retains the familiar Gore C3 delivery system functionality, but also have enhanced device positioning, temporary attachment fiber for better cannulation. What makes this device unique, I think, is its ability to angulate. We can adjust the angle period to proximal trunk deployment, and also during repositioning after the proximal trunk has been deployed. So this is made possible by an angulation wear, We also call it J-wire, designed to adjust proximal device angle to optimize cell within flow lumen. This device can be angulated in any rotational position. The orientation of the quadrilateral gate or leading tip doesn't matter. The angulation wire naturally follows guide wire, curving in the directions of least resistance. To improve repositioning of trunk, I recommend retracting the angulation wire using stiff section of guide wire, and importantly, avoiding rotating the trunk while angulation wire advanced. Now, let me show a case to illustrate how E-axis system works in practice. This is a very large AAA case. The diameter of the AAA is more than 9 centimeters, with very severe angulated neck. The angulation alpha was more than 100 degrees. So I think this case was very suitable for E-axis system. During the procedure, after routine angiogram, the main body of the E-axis device was advanced to the infra-aortic neck, which is desired location. And then we withdraw ambulance wire to soft section, and then after advanced angulation wire to achieve a better angulation. After the first stage deployment, we performed angiogram to check proximal sealing. So at this time, the proximal stand row is full diameter, but the trunk body is only 70% of full diameter. So after the contralateral leg deployment, the main body and ipsilateral leg were fully deployed. And then the angulation wire was retracted and the delivery system was removed. This is the final angiogram. It confirmed no endo leak and good patency of the stent graft. 1 month follow-up showed excellent device position and sustained cell, and no evidence of migration and endo leak was observed. So in conclusion, treating AAAs with hostile neck adenectomy remains one of the toughest challenges in EVAR. With the adjustable proximal control offered E-axis system, we can now confidently manage most of these challenging anatomies, particularly in highly angulated necks. Thank you so much for your attention. Thank you.